Today, we'll be discussing about the pathways of spread when the middle ear is involved by an infection, how the infection spreads beyond the confines of the middle ear into other structures. These complications of otitis media was common with acute otitis media in the pre-antibiotic era. Now, most of the acute otitis media we treat with antibiotics and the response is good. And complications are more seen in chronic otitis media due to the prolonged involvement of the middle ear. So, how does the infection spread? That are the pathways of spread. First of all, the infection can spread through preformed pathways. So there are already existing pathways that connects the middle ear to the inner ear and to the brain. That is, it can be the oval window, the round window, the internal acoustic meatus, the cochlear aqueduct, the endolymphatic sac, etc. Also, there can be a genetic dehiscence or a congenital dehiscence of the bone. That is, there is a patent temporal bone suture or a dehiscence of the floor of the hypotympanium exposing the jugular bulb, or there is a dehiscence in the tegmen that can cause the spread of infection from the middle ear to the surrounding structures. A dehiscence in the bone can be caused due to problems like any trauma causing a skull fracture or temporal bone fracture or a previous surgery or any neoplasm that has eroded the bone. So the infection can spread via these routes. Then there is a condition known as perilimb fistula, via which the infection can spread from the ear to the inner ear and to the brain. In patients who get recurrent attacks of ASOM, a coalescent mastocytitis would have happened and it would have healed, but it would have left a tract. So a patient tracts for the spread of infection. So during a next attack, via this tract, the infection can spread. The second pathway is via bone erosion. So bone erosion is said to be the most frequent and most common mechanism of spread of infection from middle ear, especially in well-pneumatized bone. Bone erosion is common in acute otitis media. In acute otitis media, bone erosion usually happens following coalescent mastocytitis. In chronic otitis media, the bone erosion happens following cholesteatoma or chronic osteomyelitis. So usually, bone erosion is a slow process. Some amount of bone erosion will be there, and granulation tissue will cover the bone erosion. Again, the infection is continuing and the bone eroding process is continuing, and then there will be pressure necrosis and the bone will give away. So this mechanism is known as hysteresis or hyperemic decalcification. How will you differentiate a spread via bone erosion and via a direct pathway? Here, in preformed pathway, the complication occurs immediately. Within 2 or 3 days, you will get a complication like facial palsy or meningitis. And when you operate in surgery, you will be able to identify the preformed pathway, skull fracture, perilimb fistula, etc. In the spread by bone erosion, it's insidious. Like there will be a few weeks time before the complication develops. So in a few weeks after the ASIM or in a prolonged chronic otitis media, the complication can develop. So before developing the complication, there will be some intermittent symptoms. So there will be intermittent symptoms before complete development of the complication. Like the patient will have some intermittent attacks of vertigo before the patient goes into purulent labyrinthitis, or mild intermittent facial palsy, or earlier grades of facial palsy before the patient goes into total facial palsy. Symptoms of meningismus before development of complete meningitis. Thus, we can differentiate the pathway spread via bone erosion and via direct preformed pathways. So, in bone erosion, during surgery, you will be able to identify the eroded bone and structures in the temporal bone. Another pathway of spread is via thrombophlebitis. Thrombophlebitis means an infected clot passes via the venules into the venous system. We know that the temporal bone has a rich network of veins, and they communicate among themselves and also with the dural venous sinuses, intracranial, extracranial, and diploic veins. So this intracranial and extracranial veins anastomose at the mastoid emissary vein, and they enter the sigmoid sinus. The sigmoid sinus drains the superior and inferior petrosal sinus. Infection can spread directly through periarteriolar spaces of Virchow Robin. There will be an abscess formation of white matter without involving the gray matter. Usually, thrombophlebitis leads to meningitis. Venous thrombophlebitis leads to abscess formation, cerebellar abscess formation. Arteriolar spread can lead to temporal bone abscess and also widespread septicemia. In thrombophlebitis also, the complication occurs early, that is within 2 or 3 days. Immediate complication is seen compared to the one in bone erosion. There will not be any intermittent symptoms or intermittent signs prior to development of the complication in thrombophlebitis also. So in all these methods of spread, we have to treat the disease, eradicate the disease, and establish a proper drainage pathway.